Hello, today we're going to be discussing neurology and discussing stroke and TIA and how these patients are going to present. What are the important clinical signs, clinical features? What are the investigations we will do as doctors? What are the management or managements that we're going to be giving to the patient? What exactly is secondary prevention of stroke? What exactly is the difference between stroke and TIA? How does a stroke present as compared to a TIA? What is a hemorrhagic versus an ischemic stroke? What are the risk factors, as well as the key things we need to keep in mind when we are clinical doctors? So what are the contraindications to thrombolysis? What is the thrombolysis window? When can we actually give tissue plasminogen activator, or when can we give thrombolysis? What are the scans we need to do, as well as the ABCD2 scale. So let's start. Now, what is the difference between a stroke and a TIA physiologically? Well, a stroke itself is basically an interruption in oxygen supply going to a specific part of the brain. And whenever there is an interruption in oxygen, when there's either decreased oxygen or a complete block in oxygen going to our neurons, that is going to be very damaging, because our neurons are one of the most, our nervous tissue is one of the most susceptible tissue to ischemia in the whole human body. So we need to be aware that TIA or stroke, especially when in stroke, when the artery, for example, is completely blocked, and it can actually cause a brain cell death, so neuronal cell death, that is then going to cause long-term implications for the patient. And that means that it's quite severe and quite dangerous. And these strokes have certain risk factors, which I'll go into. And because the neuronal tissue is so susceptible to ischemic damage, we need to be aware that we need to act fast. B, strokes are very severe and very, very quickly progressing, sudden neurological deficits that can arise. Now, just to throw it in there, we have the B fast mnemonic, and B fast are the signs that you're looking for in stroke patients. B is for balance, E is for eye disturbances or visual disturbances, F is for facial drooping, A is then for any kind of arm weakness, S is for speech problems, and T is time to call 999. So we need to be aware of that. Now, those are the signs. Remember that some strokes can present silently, and some strokes will have these facial drooping, arm weakness. So those are the major signs that you're looking for. How will a patient present? Now, look, TIA and stroke, both are ischemia. Both TIA and stroke are ischemia. So, and the thing is, with TIA, well, both TIA and stroke are ischemia. If it self-resolves on its own, that is what is considered a TIA. However, if it stays after 24 hours, if the focal neurological deficit stays beyond 24 hours, then that is considered a stroke. Okay? So that's the clinical differences between a TIA and a stroke. Now, what happens? Your patient is coming in with focal neurology, symptoms of stroke. What is the first thing you're going to be doing? The first thing you're going to be doing is a CT brain and find out the time of onset of the stroke. Okay. Why are we doing a CT brain immediately? Like, first, after we find out the time of onset of the stroke, why will we do a CT brain? Because we need to exclude hemorrhage. The basis of doing a CT immediately also is to exclude hemorrhage. But remember, the clinical history that's the most important here is what? It's the time of onset of stroke. How long ago did this patient present with these focal neurological symptoms and signs? Why? Because we have something called a thrombolysis window. Thrombolysis window is 4.5 hours. You can only administer thrombolysis as a doctor if the focal neurology or if the stroke had started within the period of 4.5 hours. So, for example, you have a patient that comes in at 6 p.m. The latest that it can, that after 10:30 p.m. you cannot give thrombolysis, because that is when the window of thrombolysis is finished. It's 4.5 hours, 6 to 10:30. Okay? Okay. Now, if you just imagine a blood vessel, and a blood vessel which has some kind of, well, firstly, what's the difference between a hemorrhagic stroke and an ischemic stroke? A hemorrhagic stroke actually is when the blood pools around and ends up going to places that it's not supposed to even go, and it starts pooling around. It's bleeding. It's actually just bleeding. It's a hemorrhage occurring within the blood vessels that is supplying the brain. Now, ischemic stroke is when the blood is simply not reaching its destination. And this is also dangerous. However, an ischemic stroke has many more options for treatment as compared to hemorrhagic stroke. Hemorrhagic stroke has limited options for treatment. Now, the difference between stroke and TIA is that TIA will self-resolve on its own. So when you see the patient, they will either have completely self-resolved neurological, they will no longer have focal neurology, okay? Or they will have it, but it will get better. However, then we'll come into how are we actually going to approach the patient as they come to you. There's something specific you need to know for when the patient presents to you, okay? And that is that when the patient presents to you, if they still have the focal neurological sign, you will treat it as a stroke, okay? I know that a TIA can self-resolve within 24 hours. However, if the patient is presenting to you and you are the junior doctor, you will treat it as a stroke. Now, so if you imagine a blood vessel, then if the blood vessel is just having if the blood vessel has ischemia, that means that the neurons towards the end of that blood vessel that are trying to be reached, they will undergo necrosis and die, and that will cause neuronal cell death. Okay, that will cause neuronal cell death. There's some region around that central area of neuronal cell death, and that's known as the penumbra. And this penumbra is still receiving blood supply from the collateral blood vessels. So that means that if you administer thrombolysis within 4.5 hours, you can still save that penumbra area. Sure, the neurons that were directly receiving blood supply from that ischemic blood vessel, they're gone, they're dead. However, there is just try and imagine an area, just try and imagine like a blood vessel that's kind of leading into like a tunnel, or like a tunnel. That blood vessel, even if there is necrotic neuronal cell death, there is an area surrounding those particular neurons which are then actually still receiving collateral blood supply. Now, that penumbra can still be saved, and that is the whole point of administering thrombolysis within 4.5 hours. Okay. Now remember that after 4.5 hours, the risk versus benefits are far greater. That if we did administer thrombolysis after 4.5 hours, the risk would outweigh the benefits, and then there would be not much point in even administering thrombolysis. Now remember, these things that I'm telling you are from the perspective of a junior doctor. These are the basics that you need to know. But when it comes to making these decisions and administering thrombolysis at a later period, or later on, you'll see there's some contraindications for thrombolysis, which I'll come to, and those specialty decisions can be only made by a stroke specialist or a consultant. You at a junior doctor level will not be expected to know nor make those specialty considerations and specialty, what's the word? Specialty decisions. Okay, so key points now. When the patient reaches you, if the focal neurology has completely resolved, what is it? TIA. When the patient reaches you and they still have focal neurology, it is a stroke. So, okay, if a patient reaches you and it seems that they have either A, completely resolved, or B, if the patient reaches you, are you going to wait 24 hours to see whether it's completely resolved? Of course not. You're not going to be waiting there for 24 hours and see, oh, okay, the textbook definition of TIA is that it must self-resolve within 24 hours, so I'm going to wait. No, you will not. Okay, you're going to be asking yourself important questions. Is this patient suitable for thrombolysis? Yes or no? The things you need to consider are, as I've already highlighted, the time of onset. What is the window period? What is the thrombolysis window? It's 4.5 hours. What are the other considerations you need to make before determining whether the candidate is suitable for thrombolysis or not? You need to be looking at the contraindications for thrombolysis. What might be the contraindications for thrombolysis? Brain tumor. Because remember, neoplastic vessels are weak and leaky, okay? If the patient has had a recent hemorrhage. If the patient has had a recent hemorrhage, or if the patient has had a recent head trauma. Another contraindication for thrombolysis might be, has the patient had lumbar puncture within 7 days? Does the patient have any kind of varices or bleeding? Does the patient have a peptic ulcer? Now, the things that I'm mentioning to you, these are absolute contraindications to thrombolysis. We might also have some relative contraindications. What are relative contraindications? Well, some people might have hemophilia. If the patient has any kind of hemorrhagic diathesis, you need to be looking at their INR values, and you need to be really taking into account and considering these relative contraindications. If the INR, for example, is greater than 1.7, that would then be a relative contraindication to thrombolysis, okay? So we do have contraindications for thrombolysis, and the clinical determination or decision making needs to be based on an individual patient basis. Now, I'm going to ask a broad question here, and that is, if the patient has presented with stroke, are we going to lower their blood pressure? What if their blood pressure is, let's say, like 190, 200 over 100? Okay, so the answer differs according to this clinical situation. No, we do not typically acutely lower blood pressure when the patient has presented with stroke. I'll tell you the pathophysiology for that in a minute, why we do not acutely lower the blood pressure. But, okay, we do not acutely lower the blood pressure typically in a stroke patient. However, but that is if they are not getting thrombolysis. If the patient is a candidate for thrombolysis, is there a cutoff blood pressure value? Yes, there is. There is a cutoff target for thrombolysis, okay? And we do not thrombolyze the patient if their blood pressure is excessively high, okay? The target for thrombolysis is blood pressure 185 over 110, okay? The thrombolysis is 185 over 110. Now, the reason why we do not lower blood pressure acutely usually is because it can be dangerous, because, like, you know how I earlier mentioned the penumbra region, which is surrounding our direct ischemic damaged neuronal tissue, that penumbra is supplied by collateral circulation, and if we acutely lower the blood pressure, that will be dangerous. Imagine that area, or like the metaphor I gave earlier, like that tunnel, if it's receiving if there's some kind of entry or doors to that tunnel from other like roads or other underground spaces, okay, and if that penumbra is relying on the collateral circulation, we do not want to acutely lower the blood pressure and then cause further damage to the penumbra area, okay? Okay. So if it's a normal patient with a blood pressure, okay. Now, let me just go back here for a second. What are the two circumstances in which we will lower the blood pressure even acutely? Okay, we will lower it even acutely if we need to meet the thrombolysis target of 185/110. Okay, we will need to acutely lower the blood pressure if we need to meet the thrombolysis target and if this patient is in fact a thrombolysis candidate. Now, the other reason why we will acutely lower the blood pressure, if the patient is heading towards something like a hypertensive encephalopathy or or if a patient has aortic dissection, if a patient has eclampsia, if the patient is heading towards nephropathy, something like that. Otherwise, we will just use, if the patient is not targeted for thrombolysis, if the patient is not, for example, if the patient is a stroke patient, but they have come outside the thrombolysis window. So now we're talking about patients that are presenting to you 5 hours later or 6 hours later. If the patient presents to you 5 or 6 hours later, the patient has a stroke, are you going to acutely lower their blood pressure? Your answer should be no. There's no need to acutely lower the blood pressure. We do not want to cause more harm than good. We will only gradually lower the blood pressure, and in that case, give something like amlodipine. Okay? All right. What is our agent for thrombolysis? Our agent for thrombolysis is alteplase. Okay? Thrombolysis is typically the management for stroke in the acute setting. So, what else about stroke management? Well, if the patient is outside the thrombolysis window, so how long does that have to be? Yes, outside the 4.5 hour time window, then what are we going to administer to the patient? We are going to give them aspirin 300 milligrams. Remember, in MI, we gave the patient aspirin and clopidogrel. Here, in stroke, we will only give aspirin 300 milligrams for 14 days. Okay, so we will give aspirin 300 milligrams on the day that the patient had the stroke, and we will keep it going for 14 days, and then we will change it to clopidogrel. Okay, then we will change it to clopidogrel. Now, let me go over everything we need to do from the investigation to the management of the patient from the start to the end. Okay. Number 1, time of onset of focal neurology. 2, CT scan to rule out hemorrhage. 3, thrombolysis window. What is the agent for thrombolysis? I hope you're saying alteplase. 4, if the patient is outside the thrombolysis window, what is the drug that we are going to give on the day and for 14 days? The answer is aspirin 300 milligrams for 14 days. What are we going to switch to after 14 days? I hope you're saying clopidogrel. Yes, after 14 days we switch to clopidogrel. Now we typically also do give statins. So for statins, you have to ask yourself, is the patient already taking statins? If yes, you will continue. You will just administer and keep administering. Okay. Is the patient not already on statins? You will start statins. In that condition, in that case, you will start statins after 48 hours. Now remember, before administering any kind of oral medication, you as a junior doctor need to take a swallowing assessment for the patient. And remember, your approach to the acute management of stroke is that you need to look at the patient as a whole, take into account the thrombolysis window, take into account any contraindications to thrombolysis that the patient has, and then think, is this a patient a candidate for thrombolysis? Yes. But if the patient's blood pressure is 220 over 100, can you acutely lower, okay, let me ask you a question. Can you acutely lower the blood pressure when the blood pressure is 220 over 100 if the patient has arrived within 2 hours and is suitable for thrombolysis? Yes, you can and you will, in this case, lower the BP. Now, why do we even give thrombolysis? Well, the tissue plasminogen activator acts like a big pair of scissors in the human body. It's the one that's acting to break down the clots and activating the body's own fibrinolytic pathway to break down that clot. And remember, that clot is what's currently blocking the oxygen and blood supply to that area of the brain. Okay, now let's move on. When we already talked about, okay, can you answer these questions? When might a patient not be a candidate for thrombolysis? If they had a brain hemorrhage recently, or if they had a lumbar puncture recently. Okay, now let's move on to something else. What happens if the patient has presented with stroke and the stroke has been due to atrial fibrillation? Can we give anticoagulants in the acute setting or even within 14 days? No. The guidelines are that if the patient has presented with a stroke and it's due to AFib, underlying AFib, you cannot give anticoagulation within 14 days of the acute stroke. We do not anticoagulate, not with heparin, not with abciximab, nothing, not within 14 days. And remember, it's not just AFib. If the patient has had any kind of valve replacement, this is even more dangerous. Please do not start an anticoagulant. And remember, keep in mind that again, we're talking from the perspective of a junior doctor. A consultant stroke specialist might make a different decision. If they have the AFib, what kind of investigation are you going to run? What kind of labs? You're going to do an ECG. You're going to do an ECG. If there was a patient, usually what do we do? Think of your mind map, think about your algorithms. If it was a patient without stroke, without AFib, you would give anticoagulants. However, in this case, if there's a patient with AFib and acute stroke, there's no anticoagulant in the 14-day acute period. Okay, now I want to move on to secondary prevention of stroke. And after that, I'll move on to TIA. Then we'll look at the ABCD2, and then we are finished. So let's start. What is the secondary prevention? Well, okay, so the management, what is the management? As we've mentioned, it's aspirin, 300 milligrams for the first 14 days. And on the 15th day, we will swap over to clopidogrel. So when do we start secondary prevention? Well, what is acute treatment? I hope you're answering aspirin 300 milligrams. Okay, what is secondary prevention? Clopidogrel 75 milligrams. Good. Okay, so when do we typically start secondary prevention? I hope you're saying after 14 days of aspirin 300 milligrams. Okay, so what about this? Can you answer this? If a patient becomes stable earlier than 14 days, can you switch over to clopidogrel? Yes, the answer is yes. So for example, if you have started aspirin and on day 3 or day 4, in the situation where the patient becomes stable, can you give clopidogrel? Can you switch over to clopidogrel and discharge the patient? Yes, you can. So the only circumstance in which you're staying for 14 days with aspirin is if the patient remains unstable. However, if at any point the patient becomes stable sooner within this 14-day period, you can start secondary prevention as soon as the patient becomes stable. You can administer clopidogrel and send them on their way home. Okay, I hope you've understood that. Now, in a TIA, if their completely focal neurology is resolved, you can give aspirin the same day, and the same day you can discharge that patient with clopidogrel. Okay? You can discharge that patient with clopidogrel the same day. Now, for TIA, what's important? Well, TIA was an and all acute, all focal neurology has resolved within 24 hours. But how will you, as a junior doctor, treat that patient who walks in through the doors? Well, for your exam and for your guidelines working, you need to know that if the patient comes with their focal neurology already resolved, you can, it's a TIA, right? But if the patient comes with the focal neurology still, it is a stroke. However, you must still treat it as a stroke. So, TIA must be at the time of assessment with no focal neurology. With no focal neurology. Okay, so what kind of score do we use to calculate the risk stratification for a future stroke? Now remember, stroke is a very, very serious condition, and quite a few patients do pass away within the first month of the stroke. Okay? Now, by the way, let me just tell you this. Before we move on to the ABCD2 thing, let's just discuss this. How will a TIA present to you? Okay, with the focal neurology resolved. We understand that. Okay, now, can a TIA ever be due to a hemorrhage? I hope you're saying no, because in no way can a hemorrhagic bleed, a bleed in the brain, self-resolve. The hemorrhage will never self-resolve. And we know, by textbook definition, TIA is something that does self-resolve. So in that case, a hemorrhage can never cause TIA. TIA is always ischemic. I know it goes without saying, and I know this is obvious, but you need to understand that hemorrhage can never be responsible for a TIA, and TIA is always ischemia. TIA is always ischemia. So, when your patient comes in with a TIA, will you be doing a CT head? Theoretically, there is no need for a CT head. Will you be doing thrombolysis? Once again, theoretically, there is no need to be doing thrombolysis. Okay, so for example, remember, why were we even doing CT head in the first place in these patients? That was to exclude hemorrhage, if you can remember. So theoretically, in your exam, you need to remember that theoretically, if the patient presents with TIA, we typically do not need to do it. Okay? So how do we treat TIA? We would treat TIA the same as a stroke, as we would treat a stroke. So, give aspirin 300 milligrams. What is secondary prevention of TIA? Secondary prevention for TIA is the same as the secondary prevention for stroke. However, if the patient is resolved, we can discharge them and send them home with clopidogrel on the same day. Are there any other questions? Okay, let me just ask you. So if there was a patient, let me just ask you some questions just to make sure you understand. If there's a patient who had a stroke and is unstable, at what point will we switch over to clopidogrel 75 milligrams? Or when will we start the secondary prevention? I hope you're saying that we will wait 14 days to start clopidogrel. Okay? Secondly, I have another question. If there's a stroke patient who becomes stable on day 3, will we switch over to clopidogrel and discharge? Yes, I hope you're saying yes, we will. Okay, now that we're done with that, we just have ABCD2 left and a few investigations to discuss. ABCD2 is used to evaluate the risk for future stroke. A is for age, B is for blood pressure, more than 140/90. C is for clinical features such as facial involvement or limb involvement. D is for duration. The options are less than 1 hour or more than 1 hour, less than 60 minutes or more than 60 minutes. And the second D, ABCD2, is for diabetes. Age more than 65 would give you 1 point. Blood pressure more than 140/90 is 1 point. Clinical features such as facial or limb involvement. Facial involvement would be 1 point, limb involvement 2 points. Duration, less than 60 minutes, 1 point. More than 60 minutes, 2 points. Diabetic, 1 point. There's 7 points. 3 or less means the risk for stroke is less within 7 days. The risk for stroke is reduced within the next 7 days. 4 or more points is a high risk patient, and it's a high risk and you need a stroke specialist needed within 24 hours. Now, important to tell you that actually the NICE guidelines have made this redundant. We do not actually typically use ABCD2 anymore. This is redundant. However, it's important just to, get an idea of, it's important just so we can get an idea of how scales may work, or this ABCD2, and how the risk may increase due to these particular risk factors. Okay, now the latest NICE guidelines, the latest recommendations are that every TIA would require a stroke team assessment in 24 hours. So it doesn't matter whether you have 3 points, 4 points, 5 points, or 2 points. Every TIA will require a stroke team assessment within 24 hours. And the follow-up investigations you are going to be doing is find out where the clot is coming from. Your investigation will be a carotid Doppler. You need to find out where the clot is coming from. You're already giving the patient clopidogrel 75 milligrams once daily, long-term basis. You are giving the patient statin, for which you need to do a Q-risk 3 assessment. And you can introduce a statin. This is most typically atorvastatin, 20 milligrams at night. Maximum would be 80 milligrams. But before introducing a statin, you need to monitor the patient and also check their baseline LFTs. Okay, you need to check their baseline LFTs. So also you need to inform the DVLA. Whether it's a stroke or a TIA, you need to inform the DVLA, and they will not be able to drive for 1 month. There is no driving for 1 month. If you need to you need to further do investigations, because you need to find out what exactly was the cause of this clot, what exactly was the cause of this stroke. You're going to do a carotid Doppler, and if the carotid Doppler shows 50 to 60% narrowing, will you do anything? Will you have any kind of intervention? I hope you're saying yes. We will intervene. If there's 90% narrowing of the blood vessel, will we intervene? The answer is no. You will not do anything at 90%, because firstly, there's no point. The vessel is 90% blocked anyway. The thing is that if you were to intervene surgically, especially, this could then cause the clot to dislodge and cause a stroke anyway. Okay, so if someone has already got 90% blocked of the coronary artery, we do not do anything. Carotid artery. The clot can dislodge and cause a stroke. Now remember, this is not sufficient basis for you to then make the clinical decision for whether you're going to intervene. Your clinical decision will rely on further investigations such as a CT angiogram, an MR angiogram. You need to do an echo to try and find out which territory is affected, which walls are affected. And remember, if it's something called like a paroxysmal AFib you suspect a paroxysmal AFib, for that, what kind of investigation would you need to do? I hope you're saying ambulatory ECG. And finally, the MRI is the most sensitive investigation to diagnose the territory of the stroke. So those are the further investigations you would do. I hope this was useful and you learned about the differences between TIA and stroke, and the clinical scenarios were useful for you to understand the different investigation, the different managements we would do. Keep checking on my website for further audio podcasts. I'm going to be covering all of neurology. And it's important that you check up on the guidelines and you're quite clear on the diagnostic algorithm, diagnostic approach to different